It's my pleasure to introduce our two speakers for today. We have with us Sally Cantrell, who's a psychologist in the Department of Early Intervention here at UCSF in the Division of Mental Health and Child Development. She is a clinical psychologist by training and provides assessment for children with mental health, developmental disorders, provides ongoing treatment for babies, toddlers, and young children. She's trained in fussy baby, trauma-informed child-parent psychotherapy, and circle of security parenting interventions. And she's had a lot of experience meeting the needs of children involved in the child welfare system, leading group programs supporting relationships between children and their multiple caregivers after removal. And she also works closely with and advocates for the needs of children in Spanish-speaking immigrant families. Dr. Susanne Herz is an associate professor and also associate clinical director in the Division of Developmental Medicine and the Department of Pediatrics here at UCSF. She's also affiliate faculty in UCSF's Institute for Global Health Sciences and the program in bioethics. Her research focuses primarily on the prevention and amelioration of neonatal brain injury and developmental disability and neurodevelopmental assessment across contexts, in particularly in low and middle income countries. They will be speaking with us today on early childhood mental health with a focus on early relational health. So with that, I'll hand this over to Sally and Susanne.
Joanne, thank you so much. And thank you all for joining us today and for inviting us to participate in your series. Susanne and I have no disclosures to make today. So we're going to be talking about early relational health in the pediatric setting and how you can apply that model there. This is a model that's also referred to as two-generation health. By the end of this conversation, my hope is that you'll have a much better sense of what temperament is and how it plays a role in these relationships. We're going to try to deepen your understanding of attachment. And last but not least, we want to help you identify red flags for relational concerns, as well as figure out how you talk to families about these. So this is a quote from Urie Bronfenbrenner, who was a psychologist and who back in 1960s developed this model of early childhood development. And it's a model that's really stood the test of time. And it focuses so much on the relationships between children and their caregivers and the systems around them. I like this model. We've got this baby situated in the center. We've got the family just outside that. And then I've circled the healthcare services. I'm thinking of this as being you. You're the people who often show up in the hospital just moments after a baby's born. They're one of the first people to interact with the family. And then it's my understanding that you have 12 well-child visits over the course of the first 3 years of life. So that's a lot of contact with the family and a lot of opportunities to see them. And it also means that you're the first ones that they're turning to when they have concerns about their child's emotions and behaviors, which means of the many hats that I know you wear, one of them is being the first early childhood therapist. So keeping all of that in mind, here's this quote. In order to develop normally, a child requires progressively more complex joint activity with one or more adults who have an irrational emotional relationship with the child. Somebody's got to be crazy about that kid. That's number one, first, last, and always. Next slide. And here is a definition of early relational health. And now I've got to move all our faces because I can't see what it says. Let me make this smaller. So that's the capacity for an ongoing engagement in growth fostering, empathic, and empowering interpersonal relationships. And if you think about it, it sounds a lot like what Urie Bronfenbrenner just said. And I love this image of this parent and this child. And traditionally, when we think of mental health, we think of it as sort of being inside an individual, but that's not how we think of it when we think about early childhood mental health. We really treat both the parent and the child. We call it dyadic mental health, and we really are addressing the relationship. This picture in particular reminds me of a quote from Winnicott, who said, "There's no such thing as a baby." And to me, that really means that infants can't exist outside of their relationships and that their very survival depends on their caregivers. Next slide.
So as Sally mentioned, we wanted to talk just a little bit about temperament and defining temperament. And temperament is really we think of it as the inborn traits or personality, all of this, many things that you guys were listing in the introduction in the chat, whether it was bossy or shy or cautious or active. So thinking along these 9 areas of activity level, ability to regulate, ability to be adaptable to new things, your persistence, your sensitivity, whether that is to being overwhelmed or to other sensations or sensory experiences, distractibility, intensity, whether you're approachable or not, and then your mood as well. Next slide. And what really matters in this young age range is the goodness of fit between the caregiver and the child, and how well those two mesh together and can function successfully together. And that does not mean that you have to have the same temperament as your child. And in fact, any of us who have a couple of kids know that kids don't have the same temperament. And I think the example for this for me is that I have one very, very cautious, introverted child. And I am not an introvert by any means. And so it took me, it was probably 6 or 7 before I kind of started to get an understanding of how he interacted with the world in a way that was so different than what I did. I kept feeling like he was missing out on something because he was so cautious, and that I should encourage him to be less of an introvert. And now that he's a teenager, I really see the benefits of his introvertedness, particularly going through COVID. It was a blessing. But that fit and how we can support caregivers in matching their child's temperament and understanding and valuing their child's temperament is really important. Next slide.
So early relational health, this is a concept that's really built on the work of attachment theory that was really can be credited to John Bowlby. He started working on this in the 1940s and worked on it through the 1980s. And I think it's really interesting to note, John Bowlby's this guy in the upper right-hand corner, that he was born in 1908, I believe, and he spent his early years being cared for by a nanny. And then when he was 7 years old, he was sent away to boarding school. And then he said later on in his life's work, one of the things he said was, I wouldn't send a dog away to boarding school at age 7. And so I think we can see how theories don't come out of a vacuum, and how he was really shaped by this early experience, and it pushed him to really focus on relationships and separations throughout his life. And he would have been influenced by the research going on around him. Spitz was focusing on the separations that children were experiencing as a result of World War II, and children who were going into orphanages, and the pretty devastating effects it had on their physical health as well as their emotional health. He would have also been privy to the Robertsons, who were doing observational studies. At that time, children went into the hospital by themselves and often had longer stays while they were there. And you could see real detriment there as well to their health and presentation. So that led to changes in visitation in hospitals. And he would have also known about the animal studies going on by Harlow that probably all of us have read about at some point in some science course as we were growing up, where they looked at the wire monkeys. Next slide, please. So attachment is fascinating, you guys, and we could honestly spend a whole seminar series talking about it. So I'm going to try to distill what I think is really important about it into 2 slides. And so this first principle or point that I want to make is that attachment describes the human and its tendency to seek comfort, support, nurturance, and protection selectively from a small number of caregivers. So attachment relationships are unique in that they are selective and enduring. We think of them as being just between you and me and likely lasting for a lifetime. It's in this relationship that children learn rules, social rules about turn taking. We also learn about frustration tolerance, and what else comes from that? Understanding the mind of others. So you can also think of attachment as an evolutionary or biological system with the set goals of safety and protection. So I think of attachment as sort of a biological imperative designed to support infant survival. Babies are born not fully formed, and therefore they need this added support. There are multiple drivers of attachment, among which one of them is the oxytocin system. And I think it's so interesting to note that while oxytocin is released during birth, it's released during nursing, it is also released when you have sensitive caregiving, meaning that there are elevations both for fathers and foster care providers. This third point, that the attachment system can be activated by a variety of conditions. So we can see it activated when a child is experiencing pain or illness, when something frightens them. And then we infer attachment based on their behavior in response to those situations. So do they move closer to their parent or caregiver in those moments? This last one, attachment behaviors are about contact seeking and maintaining a proximity. Really, I just spoke about that. Next slide. All right, so some more key principles of attachment. Attachments are formed through repeated child caregiver contact and experience over time. It's not enough just to have the sole biological connection or early skin-to-skin contact. Although we're seeing that those kinds of interventions are really useful and powerful in supporting relationships, they aren't the only thing that's needed. Attachment also becomes apparent in the second half of the first year of life. We can see that initially infants are comfortable interacting with almost anyone, but by the time a child's 7 or 8 months, they start to have object permanence. They can tell when their caregiver has left the room that they still exist. They haven't disappeared, and so they could work harder to get them back. And so that's what we're looking at there. Infant behavior becomes guided by what are called internal working models. And by that, I really mean we're creating templates for how the future relationships a child is going to have. And that really, you can't underestimate the importance of that. Young children who feel understood and valued and learn that they can rely on caregivers really have better outcomes in terms of their social relationships with peers as adults, and even reductions in their psychiatric disorders over their lifetime. This last point is that children can form multiple attachments, although they're likely to have a hierarchy of attachments. And I'd also make the point that children can form somewhat paradoxically attachments to maltreating caregivers. And again, that goes back to their need to have someone to support their survival. Next slide.
So, and as you all probably know, the fetus is actually receptive to what's going on in the environment around it. It can hear sounds. It can often, in many cases, see light. Later on in gestation, there's at least some research to suggest that they can taste different foods that the caregiver is eating. The pregnant person is eating, and the amniotic fluid will have a different taste. And they respond to stresses, and they respond also with genetic changes to high stress level in the mom. And there's work just coming out from Nikki Bush's group at UCSF that's going to be showing some impact of interventions to reduce that level of stress during pregnancy, and that's impact on both maternal and child outcomes. So that's a very important time as well for those of you that are seeing pregnant people with their second child, or people coming for interviews for their pediatrician. Next slide. And then when babies are born, they have some preference for their birthing parent. They know what that smell is like, and they will be more likely to go to, say, a breast pad or chest pad from a birthing parent's with birthing parent's breast milk on it than with somebody else's. And they will respond more to voices that they have heard in utero, and particularly to the birthing parent's voice. That's preferred initially after birth. And I think the other key point here, when we were talking about trauma and trauma-informed care, is that they are also reactive, even in sleep, to stresses going on around them. So when parents are arguing, when there's violent episodes going on in the home, a sleeping baby will have heart rate changes, blood pressure changes, things like that, even if the caregivers don't feel as if they've woken the child or had any impact on them. Next slide.
So I wanted to share this with you guys as well, given what we've all been focusing so much on adverse childhood events, and we know how important they are. But there's also research coming out talking about positive childhood experiences and how they can actually mitigate the negative effects of adverse childhood experiences. And here's a graph that I'm just going to walk you through quickly. I want us to focus on that far right side where there's a square. And I want you to know that the y-axis here is level of depression. And this group in this far right are all adults, and they've all experienced high levels of trauma over 4 ACEs in their childhood. But they also asked these adults about their early childhood positive experiences. And if you look at the yellow bar, that shows you people who had reported 0 to 2 positive childhood experiences. They had high levels of depression. Then if we move to the green bar, those people had 3 to 5 positive childhood experiences. And those, we can see that bar reducing. And when you get down to those blue folks that have high numbers of positive childhood experiences, their likelihood of having depression looks like about a third to me. So what you might ask is, well, what are those positive childhood experiences that we need to cultivate? And one of them that stood out to me was those families reported feeling safe and protected by an adult in their home. Next slide. So how do we help people feel safe and secure when they are young? Well, this is a graphic that I love that comes from the Circle of Security intervention that's based on attachment principles. And this is used to help parents identify what their children needs at any point throughout the day. And in this slide, the hands really depict the caregiver. And we can think of a child as needing their caregiver to provide them a secure base up on the top of the circle in order for them to feel confident and secure enough to go out in the world and start to explore. Sometimes when kids are out exploring, they still need help. They still need their caregiver. They need someone to make sure they're watched over and staying safe. They need someone to get excited about what they're doing. They might need help if they can't quite reach the swing, whatever it is. Then we also see this bottom half of the slide that can be thought of as proximity seeking, or when attachment behaviors are really visible. And that's, a child gets scared, a child stubs their toe, something breaks on the playground, and then they really need their caregiver to protect them, to help them, comfort them, to delight in them, or to organize their feelings. And I'm seeing we're getting close to the end of our time. So let's move on. Next slide, please. Susanne, your sound is off.
Thank you. Sorry about that. When we talk about parent-child interaction, again, thinking back to that, that fit and that give and take that people have with their children, we see a whole bunch of different types of interaction here. And some of these will kind of scream out to you for differential diagnoses as well. So we want to see joint attention. We want that to come both from the caregiver and from the child. So if the caregiver sees something exciting they want to share with the child, we want them to look over at the child and point to it and make sure that the child's seeing it the other way around as well. So if the caregiver's not doing it, it may be a mood issue for the caregiver. Maybe they're sad or depressed or distracted by stress. If it's the child not doing it, then we need to be thinking about autism or some social communication kind of delay. There's that serve and return that Sally talked about, and it's this sort of big give and take and mutual engagement that's so important for a child in learning and in being emotionally supported. And then there are ruptures and repairs, and if you how families negotiate those situations when there's been an upset, when there's been a period where things didn't go well, that is really important as well. So it's as Sally was highlighting, that the positive experiences can really counterbalance some of the negative ones. If that repair doesn't happen or is mismanaged, it can be really hard for the child and the caregiver. And we want as many pleasurable and happy experiences as possible for caregivers and their children together, so that they can regulate together and support each other. Next slide. So somebody's gonna play this. This is like, if you just bookmark this video, and when you're feeling down, play it for yourself. I'm hoping that somebody can get it to play We had trouble with it from the slide, so we may need to go to the, yeah. Some of you may have already seen this video before. It's an example of the give and take that can happen when it's really working well. It's actually also a really nice example of early language development. You'll see that as well in here, and social communication. Hopefully.
I'm having some technical issues, so I'd encourage people to watch it on their own later. I just dropped the link into the chat. It is so much fun. If you're having a bad day, this is a great video to watch.
Do you want me to just try really quick, Joanne? See if I can make, or we not have time to share it?
I think we're a little low on time, so
Okay.
maybe we should
Okay.
go.
So, but do watch it. It's just absolutely adorable. Maybe at the end, if we have time, we can get it to play. Okay. So next, we need to go back to the slide deck, I think.
Yeah.
Oh, here it goes.
Did you understand it though? No.
Okay.
Oh, not this one. This one is right now. Yeah, that's right. That's what I was wondering. I don't know what they're gonna do next season because they did some stuff this time. Exactly what I was thinking. Oh yeah. Right. Don't bring that in. You know what I'm saying? Don't do the same stuff. You know what I'm saying? Yeah, I think that. Yeah.
So that not just that nice, beautiful give and take of a conversation. There's no words in that. That's immature jargoning. That baby is just babbling away, but the gestures, the engagement, the response from the adult is so lovely. And they go on like that for a while. It's really very cute. Okay.
I hope that left you guys with the same warm feeling it did me. I think they really have that serve and return down, and that idea of synergy and contingent relationships is definitely evident in that video. So here's what we want you guys to tune into in terms of relationship concerns and when you're focusing on a child. You want to think about, oh, sorry, I think this is your slide, Susanne. I apologize. I'm stepping all over it in an effort to move us forward.
No, go for it. Go ahead. Go ahead.
If you see a child being reckless or clingy to their parent, hypervigilance, role reversal is one of those things where the child is meeting the emotional needs of the parent as opposed to vice versa. Socially indiscriminate behavior often happens when a child's had multiple caregivers and hasn't had a good chance to really formalize their attachment to one, in which case they use all adults in sort of an equal way. And it's important to keep in mind that this is relationship specific, so it's not inherent to the child, but it's something that might be going on just with that one person. And so then we see distortions of their secure-based behavior, as you can see by this figure on the left. Next slide. The flip side is also looking at the parent to try to figure out when there's a relationship concern. We have misattributions. The place I see this most commonly is when you have maybe a 12-month-old and a parent says something like, oh, they're so violent, like they're hurting me, they're always hitting me, they're so aggressive. And then if you can step back and look underneath that, we can see that there's intergenerational transmission of trauma or concern that maybe there's been an abusive relationship where they're layering on that idea onto a child, and that's limiting that child's opportunity to be their own self. So we want to intervene in those moments. Predominant negative affective tone or lack of investment, both can be signs of caregiver depression or anxiety. And so that's a great moment to use the PHQ-9 or the Edinburgh to assess that in parents. Over controlling behavior, role reversal, we mentioned. Goodness of fit goes back to temperament. Next slide. All right, so here we're coming to the end, and this is how we're going to think about how you talk about relationships with families. Let's just start by thinking of relationships as vital signs in early relational health. It's as important as checking their temperature and blood pressure. One of the ways we can check it is just by asking, like, hey, how's it going? How's your relationship with your child going? How are you feeling about it? How are you doing as a parent? And support comes from these trusting relationships. So you have this opportunity over the 12 well visits to build that relationship with a family that is non-judgmental. I often, when I'm trying to elicit a conversation about this, say something like, parenting is the most challenging job there is. I have a day job and it is not nearly as hard as my night job. I also might say something if I'm seeing a lot of challenges. It's important to me that you feel fulfilled as a parent and that things aren't so hard for you or your child. And it's at this moment that I think it helps to offer hope. And I can imagine if I was in your situation saying something like, look, there are people who are really trained to help children and parents with their relationships, and I'm happy to refer you to one of these folks. I also want to give you permission to not know why the relationship is presenting with challenges. I often feel super overwhelmed when parents tell me all the things that are going wrong. And what I like to say to them is, I don't know yet, but we're going to work on figuring this out together. Next slide. So tips for talking about these red flags. First off is let's quit talking about them as red flags. Let's talk about them as opportunities or portals of entry. And I think parents who are worried about their relationship with their child are going to feel gratified that you are noticing it and willing to engage with them about it. Notice what's happening to you internally. Do I have an echo? Is this driving everyone crazy? It's okay. Okay. So you want to notice what's happening to you internally. If you feel like overwhelmed by the conversation, I often take a breath before I knock on a door when I know it's going to be a hard conversation and settle myself. You want to try to see the parent, the child. You see the child the parent sees. So if that child looks beautiful and bouncy to you, but the parent sees someone who's really difficult and naughty, use their language to talk about their child with them. It can help to attend to the child's strengths as well as weaknesses, so the parent feels that you're seeing a bigger picture, not just the problems. If in your office you're seeing difficult moments, I often see those as opportunities to co-observe and narrate what you see. Like, I see you're trying to help them learn to turn the pages one way, but they don't want to, and now it's caused this great big problem, and he's crying, and it's hard to calm him down. Is this how things go normally? To distinguish whether you're just seeing one random thing versus what's always going on. And then one of my colleagues recently said, Sally, you are always prescribing play. And so whenever I get a referral and there's a concern about the child's behavior or relationship, one of the first things I do is ask, how are you feeling about your relationship with your child? Parents will often pause, take a deep breath, and they say, here's something that we can do to work on that right away. It doesn't have to take long, but give 10 minutes of time every day where you're really focused on your child. It's not where you're asking questions, but you're dialing in, observing them. And I have included a reference about supporting families with play, because it doesn't always come easily. So I would say prescribe play to everyone. Thanks, you guys.
Fantastic. Thank you so much for this great talk on early relational health.